Hello, everybody. My name is Dr. Zubin Dev Sharma, and I am a senior consultant in gastroenterology at Fortis Memorial Research Institute in Gurgaon, in India. And I'm here to talk of our recently published article in GIE, that is the top tips of performing a diagnostic rectal endoscopic ultrasound as well as assessment of the sphincters. So, with this article, we hope that readers can use this as the starting point of performing a good diagnostic rectal echoendoscope examination, as it offers a standardized approach towards performing the diagnostic rectal EUS. In one of the top tips that we have given, we have mentioned that using a radial echo endoscope for performing a diagnostic EUS is the best, as the radial echo endoscope gives you a nice 360-degree view of the surrounding area and a complete assessment of the sphincters. At the same time, it also recommends that you do a good rectal examination prior to performing the rectal EUS. There are few tips in that which can help you to give better outcomes, like doing a good PR examination, also to instill around 250 ml of deaerated water into the rectum before you actually start doing the EUS. Another important tip would be to distend the urinary bladder because that serves as a natural landmark when you are performing the EUS. It's also quite important that you are well versed with the anatomy in both males as well as females of the perirectal surrounding area before you perform the rectal EUS. Now, as similar to the pancreatobiliary EUS, I think it's very important to have a very standardized and clean approach while doing a rectal EUS. The way we do it and the way it's been mentioned in the article is that you go to around 25 centimeters from the anal canal. That's where you will see the common iliac artery bifurcation, and you start withdrawing from that. Once you start withdrawing, you will immediately see a distended bladder, and around the bladder, you will see the surrounding structures. In a male, you will see the seminal vesicles as well as the prostate. In a female, you will see an air-lined tubular structure that will be the vagina. And once you start keep pulling out, you will come to the assessment of the rectal wall. You should increase the frequency there, instill some deaerated water, and that should give you a nice view of all the layers of the rectal wall, which can be extremely useful in conditions like polyps or rectal malignancies. And when you come out into the inner canal, you can divide them into upper part as well as the lower part. In the upper part, you can identify the puborectalis sling. You can also identify the inner circular rear of the rectal wall, transitioning into the internal anal canal sphincter, which becomes like a hypoechoic, nice whole 360-degree structure around your scope. And when you pull out further into the lower inner canal, you will start seeing some mixed echogenicity, some hyperechoic structure, and that will commonly be the external inner sphincter, which with age tends to become more hyperechoic and thin out. Now the internal sphincter is around 3 mm in its thickness, whereas the external would be around 7 to 9 mm, but this can vary between patients to patient. Now, doing a standardized approach is very important because once you start doing it in a standardized manner, you will start picking up a lot of abnormalities. It's extremely useful to perform a rectal EUS to differentiate T1 versus the T2 disease for rectal malignancies, although MRI is the standard of care, but rectal EUS has a good sensitivity in a recent meta-analysis. It had almost 89% and around 94% sensitivity and specificity. At the same time, to assess the depth of involvement in rectal polyps and neuroendocrine tumors, it's useful to perform a rectal EUS as you can plan your endoscopic or a surgical resection in them. Coming to the inflammatory conditions like IBD, it's quite accurate to differentiate a Crohn's and ulcerative colitis, given its wall characteristics in patients where the endoscopic assessment has not been conclusive. It's also useful in conditions like SRUS to differentiate them for IBD and malignancies. You can see the splaying of the muscle layer and the thickening of the submucosal layers. So to conclude, I think this article should be a good starting point, as I said, and some of these small tips may be useful to perform a good diagnostic rectal EUS. And I hope the readers will enjoy this. So thank you so much for the information.